I guess we'll talk specifically about the clinical side of monoclonal antibodies later on, but it's not fair to say they don't get in the brain. What's fair to say is that there's a significant decrement, you might say, and if you look at the plasma CSF ratios, and if you look on any reputable website like the Mayo Clinic laboratories, for example, or even the UCSF laboratories, you see that the IgG in the CSF is about 1,000th the concentration that is in the blood. But you'll also see that there's a range, and there are, where this has been measured, you can get a distribution of up to 1 in 300 within the CSF of IgG that you would inject in the periphery. So I agree with you that most of it doesn't get there, but I don't know how much is enough, and I know for a fact that there's a variation in the absorption. And we're going to talk about the clinical results later on, but I think we ought to keep on the table the possibility that some part of the enormous variation we're seeing in the clinical outcomes, from incredibly wonderful to absolutely useless, may have something to do, among other things, with distribution. I don't think the last word's written on that yet. That's why I'm looking scared.
What about the aura, Stu? What happens in the brain?
Well, from a neurology standpoint in practice, it's always worth emphasizing that aura does not clinically accompany every attack of migraine or in every patient. Probably only occurs between 20 and 30% of patients. And so that having been stated, I want to go back to what David said about the glutamatergic common final pathway that appears in a lot of what we know about the genetics of migraine. Too much glutamate in the synapse, not enough glutamate taken back up, pump failure with respect to glutamate, more glutamate available post-synaptically. And what we know about aura is that the portal to aura probably is primarily activation of the NMDA glutamate receptor. And in fact, CGRP does have a role in enabling that NMDA glutamate receptor at the cortical level. And so it is interesting to think about future targets with respect to aura in terms of having anti-glutamate effects. And we frequently use, for example, magnesium, which plugs the NMDA glutamate receptor. We use partial NMDA glutamate antagonists, such as memantine and dextromethorphan included drugs, to work on aura. But what's most interesting to me about the monoclonal antibodies has been what appears to be equal effectiveness in preventing migraine with and without aura. And that suggests, again, that migraine may be migraine. There may be more commonality than we initially thought.
You know, it's extraordinarily exciting. People have made a monoclonal antibody against the NMDA receptor. They then looked at the protein sequence of the epitope, and they've created a small peptide that goes to the NMDA receptor, blocks it, and goes through the blood-brain barrier. And it'll be extraordinarily, that's in clinical trials now for depression. It's extraordinarily interesting to see if that blocks the aura and proves your hypothesis.
It would perk us all up.
Yep. Last but not least, the trigeminal vascular system. It's interesting. When we grew up 1,000 years ago, migraine was a vascular disorder. The aura was due to vasoconstriction. The headache was due to reactive vasodilatation. It's gone. So now they invented the trigeminal vascular system, believing it was the interaction between the nerves and the blood vessels. I think, as David and we've talked about before, I think the trigeminal vascular system interacts with the brain. It may turn out that you cannot have migraine pain without the trigeminal vascular system, and you cannot have migraine pain if the brain's not built right. So I think it's not A versus B, it's both. There are systems that interact with each other, and it's the defective interaction of the system that results in migraine.